Marnina Budni, and welcome everyone to Grand Rounds for this week. It's lovely to have such a strong contingent in the room, and welcome to those joining us online. It's my great pleasure to introduce the NIMMO Prize for this year. It's always a wonderful roundup of our young researchers, so it's open to medical officers across Carlin who have worked with us in the past 12 months and who are early in their career, presenting substantial research that they've undertaken. I'd like to acknowledge that we meet today on the traditional lands of the Kaurna people. I pay my respects to their elders, past, present, and emerging. I'm very pleased that we've got a lovely panel of judges here to do the honours. We've got Professor Vidya LeMay from Rheumatology, we've got Professor Paul Reynolds from Respiratory, and of course we've got our visiting NIMMO Professor, Associate Professor Christine Jackman. So what we'll be doing is the candidates will have a very brief period in which they will outline their work. So it's only 6 minutes, I believe, and 2 minutes of questions from the panel. And then there will be judging performed today in real time, and we'll announce the winners after the conclusion. So we're going to start. Is it all right, judges? We're okay? Some last minute raised eyebrows there. All right. All right, excellent. All right, I'm reading the room wrong. It's okay, it's all good, everyone. So the first category is for full-time research, and we have only one contestant for that. So I'm just going to get his slides up now and ask Jonathan to come up. Thanks very much, Jonathan.
Thank you, Professor Thomas. Ladies and gentlemen, I have no disclosures for this presentation. Atrial fibrillation and heart failure with preserved ejection fraction are two common cardiovascular conditions which are closely related. Both conditions share risk factors and also have common clinical sequelae. In addition, both conditions are also associated with left atrial disease, providing a potential mechanism for the close relationship. However, the influence of HFpEF in patients with symptomatic AF is unknown. We hypothesize that patients with symptomatic AF frequently exhibit HFpEF according to established invasive hemodynamic criteria. We further hypothesize that the coexistence of HFpEF is associated with a more advanced left atrial cardiomyopathy, and that this coexistence is associated with important functional limitations. In order to investigate this hypothesis, we studied consecutive patients with symptomatic AF who were due to undergo an AF ablation procedure. The primary exclusion criteria were a reduced ejection fraction of less than 50% or a prior diagnosis of a cardiomyopathy. The central component of this study was establishing the diagnosis of HFpEF. This was done invasively at the AF ablation procedure. The diagnosis was based on mean left atrial pressure, as outlined in a recently published scientific advisory on HFpEF from the American Heart Association. HFpEF was diagnosed when baseline mean left atrial pressure was greater than 15 millimeters of mercury. Early HFpEF was diagnosed when baseline mean left atrial pressure was less than 15, but rose to above 15 with 500 mils of saline infusion. The remaining participants were diagnosed with no HFpEF. Prior to hemodynamic assessment, all participants underwent a series of non-invasive investigations for the assessment of left atrial cardiomyopathy. These investigations included resting and exercise echocardiography and blood sampling for NT-proBNP. Left atrial cardiomyopathy assessment was completed invasively using a novel protocol for the assessment of left atrial compliance. We also assessed left atrial electrical function using high-density electroanatomical maps. All participants also underwent a functional assessment involving cardiopulmonary exercise testing and assessment of patient-reported AF symptom burden using the AF symptom severity questionnaire. Left atrial compliance was assessed invasively following transeptal puncture. Using a sheath in the left atrium, we infused 15 mils per kilogram of normal saline directly into the left atrium. Throughout this infusion, we monitored left and right atrial pressures and left atrial diameter using a transesophageal echo probe. Left atrial compliance was calculated as the change in left atrial diameter divided by the change in left atrial pressure. After exclusion of patients meeting pre-specified exclusion criteria, we ultimately included 115 participants in our study cohort. Of these 115 patients, 48% demonstrated the hemodynamic features of HFpEF. A further 25% had early HFpEF, whilst only 27% had no HFpEF at all. The vast majority of our cohort, therefore, had either HFpEF or early HFpEF. In terms of baseline characteristics, there were no significant differences in age, sex, or type of AF across the three groups. However, the HFpEF group demonstrated a higher burden of cardiovascular risk factors with increased BMI and a higher prevalence of hypertension. Invasively assessed left atrial compliance was significantly reduced in the HFpEF and early HFpEF groups. Underlying these differences in compliance were greater increases in left atrial pressure and reduced left atrial dilatation with saline infusion. Associated with these differences in left atrial compliance, we also saw differences on echocardiography. As expected, left ventricular diastolic function was significantly impaired in the HFpEF group. However, we also saw differences in left atrial mechanical function, with reduced left atrial emptying fraction, both at rest and with exercise, seen in the HFpEF and early HFpEF groups. In conjunction with these differences in mechanical function, we also saw differences in electrical function. In total, 42 participants undergoing first-time AF ablation underwent left atrial mapping in sinus rhythm and were therefore included in this electrical analysis. Here, we show representative electroanatomical maps across the three groups. The colors are standardized such that red represents areas of low voltage and purple areas of high voltage. As you can see, there is a gradual decline in left atrial voltage across the three groups, and this is reflected in the global left atrial voltage data. We also saw reduced conduction velocities in the HFpEF group. Both HFpEF and early HFpEF were also associated with important functional limitations. Both groups demonstrated reduced aerobic exercise capacity and increased AF symptom burden. In conclusion, we have shown that up to 73% of patients with symptomatic AF have either HFpEF or early HFpEF based on invasive hemodynamic criteria. But HFpEF is characterized by reduced left atrial compliance, reduced mechanical function, and electrical remodeling. Finally, we show that HFpEF and early HFpEF are associated with important functional limitations, including reduced cardiorespiratory fitness and increased AF symptom burden. Taken together, these data highlights the influence of HFpEF in patients with symptomatic AF and may provide a novel therapeutic target for the treatment of this important cohort of patients.
What is the incidence of HFpEF in patients who are matched for risk factors but who don't have AF?
Well, the incidence of HFpEF in patients that are matched for risk factors but don't have AF, I think it's around 30%. So we powered this study based on that data, and we estimated that the prevalence of HFpEF in this cohort patient would be a little bit higher than that, knowing the pathogenesis of AF. And so we powered it according to 40% prevalence. But so this data suggests that patients with AF have a higher prevalence of HFpEF compared to those without AF.
What is the advantage in identifying early compared to established?
Well, it's sure. So early HFpEF is a recognized clinical entity, and it's been shown to be associated with poorer prognosis and equivalent prognosis to those with established HFpEF based on invasive criteria. So it's a really important clinical entity. It's really clinically significant, and absolutely, if we can identify these patients, then we can instigate earlier treatment and hopefully reduce the chance of them progressing to fulminant HFpEF. The challenge, of course, is being able to test for that because it requires invasive testing. There are some non-invasive testing tools available, but the gold standard is invasive testing.
Whether, as you mentioned, it's quite invasive testing to detect this, were there any adverse outcomes to the invasive testing?
Well, all participants are undergoing an AF ablation anyway, so we are doing exactly the same thing that we would for an AF ablation. All we're doing is when we have the catheters in the left atrium, as we're preparing to do the AF ablation, we're testing their pressures and giving some fluid and seeing how the left atrium responds to that fluid. We did not have any additional complications related to our study protocol in this entire cohort of 115 patients.
Thanks for that. So now we'll begin the part-time researcher category, and I'll welcome Joshua up to present first. Desperately looking for your slide. Oh, oh that one. Sorry, Joshua.
No worries.
One job and
All good to go. So this is a very exciting moment for me because it culminates the background of a lot of work that's gone in. What I'm about to present is very simple, but a lot has gone into it. I've been very lucky to undertake a PhD with Carlin's support for about 1.5 years now, and I've been able to look into many aspects of surgical recovery. One that I've gave a lot of thought to is discharge planning, which is currently very complex and also difficult to predict. So I put to you as clinicians, how do you plan discharges? I'm sure if I surveyed the room right now, we get a lot of different answers, and that's inherent to the problem. There's a lot of subjectivity and a lot of variability in how discharge planning is done. And currently there's no actual measure or way to quantify a patient's readiness for discharge. One thing I'm sure you all factored in to the process is objective vitals and lab data within Sunrise. But currently there's no way to synthesize all of that data in real time and provide a predictive measure of a patient's readiness for discharge post-operatively. Well, that is until now. What I want to share with you is the predictive measure that can provide this quantification of a patient's readiness for post-operative discharge in real time, provided at no cost, and also provided in a way that gets more accurate as time goes on. That's because it's an artificial intelligence measure, and specifically within artificial intelligence, a machine learning approach. What we've done is taken data, objective data from vitals and labs in Sunrise, funneled that through a machine learning algorithm that we've derived and trained, and then used it to produce a predictive measure of readiness for discharge on a scale of 0 to 100. I've called it the Adelaide score. What it is, on a scale of 0 to 100, a patient's post-operative readiness for discharge after general surgery. Just to reinforce, it's an artificial intelligence measure. It can be done at real time and updates ongoing. It's done for free, and it gets more accurate with retraining and more time going forward. It's very realistic, like in the future, you could have the Adelaide score sent directly to your phone or computer and give a quantification of a patient's readiness for discharge in real time. I'd like to thank Carlin for this because we used Carlin data and Carlin HREC approval going forward. And in the process of validation, we analysed just under 9,000 general surgery patients. This was done across the RA and the QE over a 2-year period starting in April 2020. What we did is we took data from Sunrise. This included time points, including ward rounds, admission, discharge, patient characteristics, vital signs, labs, and also pain scores. We split these data into 3 data sets to train the algorithms. So first you had a training data set, a testing data set, and then finally a validation data set. Within the machine learning analysis, we use the following models. First, XGBoost, second, a random forest model, and then a logistic regression model as well. Within the process of derivation, we analyzed over 42,000 ward round note times. They were each taken as different events. At each ward round note time, it was ascertained whether that specific ward round note was within 12 or 24 hours of the patient's ultimate discharge. At each time point, then we took objective data, that is the labs and vitals, in the preceding 24 and 48 hours, and then included these in the analysis. The primary outcome was the classification accuracy of the machine learning models for predicting discharge within 12 hours, but we also looked at 24-hour discharge as well. So for the results for within 12 hours, for the logistic regression model, it had an accuracy of 0.80 and 0.81 respectively, an AUC of 0.72 and 0.73 respectively. For the random forest, accuracy of 0.84, 0.85 respectively, an AUC of 0.84 for both. XGBoost had an accuracy of 0.84 and 0.83, and AUC of 0.87 and 0.85. Expanding this out to within 24 hours, logistic regression had an accuracy of 0.78 and 0.79, AUC of 0.73 and 0.73. Random forest had an accuracy of 0.83 and 0.84, and an AUC of 0.84 and 0.83. XGBoost was around similar values as well. What can we conclude? I think it's remarkable overall is that a machine learning derived algorithm, the Adelaide score, successfully predicts hospital discharge within the next 12 to 24 hours. It uses objective data, means it's translatable globally. And within this current analysis, random forest model performed the best. In the future, however, we need to prove that it benefits patient outcomes. This is through external validation and implementation studies. Throughout this process, my aim is to market Adelaide on a global scale. So in the future, when asked, how do you plan for patient discharge? First ask, what's the Adelaide score? Finally, I'd like to give thanks to those who have already supported the Adelaide score and its development and derivation and validation.
I guess the obvious question is, how does this compare with expert judgment on whether someone's going to be discharged or not?
So that,
I guess that's where we're trying to ask.
yeah, so that will come in, well, first we need external validation in a data set other than Carlin. And then following on from that would be an implementation study where we compare the algorithm or expert judgment supplemented with the algorithm versus standard care currently. So it'll be a prospective study in the future. Take a full-time year, so I hope to do it next year.
It looks like you're picking up a lot of physiological data in the algorithm. What about the social data?
Okay, so we've analysed that to some degree in natural language processing. So in a separate study, we've done this looking at ward round notes and also discharge summaries. We've found that there is a bit of a gap in that the social data is mainly captured post-discharge. So when the patient goes out into the community, we actually have no record on the electronic system that captures a lot of the social data that you're referring to. The best we've found so far is the natural language data currently on the EMR, but we're hoping in the future we can supplement that and get more accurate social data via like post-discharge surveys or things that have follow-up going forward. Well, the main limitation is that we don't know what the patient outcome benefit would be at present. So we have accuracy numbers, which, given how complex discharge is to predict, it is these are good numbers. But the main limitation is that at present we have no idea how this translates to actual patient outcomes. We don't know how it translates to cost savings. That's the main limitation at present.
Next, I'll call up Emily. Is it moving on? Yeah. Where is it? Oh, of course, the one with your name. Thanks, Emily. Well done.
Thank you very much for the opportunity to present my work today. I'm presenting my research project looking at the association between snoring and hearing loss in patients with obstructive sleep apnea. As we know, OSA is common, with snoring being the most common symptom. Snore noise levels can reach around 80 decibels, which is close to heavy city traffic, and very near the 85 decibels listed at which there is a risk of permanent hearing loss. Hearing loss can occur by both mechanical damage to hair cells from noise itself, and additionally in OSA, hypoxia can lead to cochlear damage. Both mechanisms result in a sensory neural hearing loss, and unfortunately the damaged cells cannot regenerate. However, progression can be halted with early intervention. The aim of our study was to evaluate if daily exposure to snoring in patients with OSA contributes to hearing loss, to explore the mechanisms further, and to our knowledge, this is the first study to review snore sound, AHI, and hypoxia in this cohort of patients. This was a prospective recruitment of patients referred for overnight diagnostic in-lab polysomnography at the Queen Elizabeth Hospital. We wanted to make this a clean data set and exclude anyone with a pre-existing risk of hearing loss. This was determined by a pre-sleep study questionnaire. Patients underwent a standard sleep study with a sound pressure level meter used to record quantitative sound data. This position was positioned 1 meter from the patient's pillow. Following this, patients underwent full audiometric assessment by an audiologist who was blinded to the results of the sleep study. Here's a nice example of one of our patients with bilateral noise-induced hearing loss with the classic notch at the 6,000 Hertz frequency. Our primary outcome was to review the prevalence of sensory neural hearing loss in this cohort of patients. We used a one-sample chi-square test to review the significance in our cohort against the known prevalence of hearing loss in the age-matched Australian population. In secondary analyses, we wanted to review differences in sleep and snore characteristics between patients with and without hearing loss, and additionally patients with different severity of hearing loss. We did this using an independent sample t-test and Mann-Whitney-Hugh to review differences in the AHI, the actual snore sound itself, as well as saturation nadir, hypoxic index, so that's times with oxygen levels less than 90%, and number of desaturations per hour. We had 113 patients enrolled, 78 were excluded because of that risk of pre-existing hearing loss. 10 were lost to follow-up, leaving us with 25 patients, a relatively even male-female distribution with a mean age of 54.7. In terms of our primary outcome, 18 of our 25, or 72% of patients, had a sensory neural hearing loss, 100% of which were deemed secondary to noise by our audiologist. Comparing this prevalence of 72% to that in the expected hearing loss prevalence of the age-matched population in Australia of 29.5%, we had a statistically significant higher prevalence with a p-value of less than 0.001. In terms of the severity, the majority of patients had a moderate hearing loss. You can see patients with a severe hearing loss wouldn't actually be able to hear normal conversations, clearly a big impact in their life. We did not have statistical significance in our secondary analyses, however, looking at the differences in the sleep and snore characteristics in patients with and without hearing loss. These are average numbers, so in blue is hearing loss, red no hearing loss. You can see the average AHI is quite similar, as is the average maximum snore. If you actually look at the maximum snore in our patients with sensory neural hearing loss, this reached around 93 decibels. There does, however, to be a propensity towards a more hypoxic burden. This is more obvious when we look at the different severity cohort. So again, we did not have statistical significance. But when you look at these groups, again, we're looking at average numbers. In red, we have patients with no hearing loss, mild hearing loss in light blue, extending to the dark blue with a severe sensory neural hearing loss. This severe group had, whilst they were older, they did have a higher AHI, a lower saturation nadir, higher hypoxic index, and more desaturations per hour. Main limitation in our study is the fact that we had small patient numbers in this subgroup analysis, likely explaining why we did not have statistical significance. The snore sound was actually underestimated. After the study, we reviewed using a noise generator, the sound at the level of the patient's head versus where our sound pressure level meter was. There was an 18.9% reduction. So that person snoring at 93 decibels, it's more likely in the hundreds. Additional subjective information may have been useful in our pre-test questionnaire, and we could have potentially used a control group. However, we did think we had increased reliability of our primary outcome by excluding any patient with a possible pre-existing hearing loss. In conclusion, this prospective study demonstrates a statistically significant higher prevalence of sensory neural hearing loss in patients with symptoms of OSA compared to the general population of the same age. The maximum snore volume in our group far exceeded the 85 decibels known in which permanent hearing loss can occur. And whilst we did not have statistical significance in our secondary outcome, likely due to the small sample sizes, we did show that patients with a more severe sensory neural hearing loss appeared to have a higher AHI and increased hypoxic burden. Moving forward, we would like to review hearing in the bed partners of patients with OSA to potentially help us differentiate between whether it is the noise of the snore itself or the hypoxic mechanism which is leading to this hearing loss. Hearing loss can result in social isolation, depression, and impaired quality of life, and is associated with cognitive decline and an increased incidence of dementia. Given our findings, it may well be suggested that when patients are referred for an OSA workup, they undergo audiometric examination at the same time. This is an easy and cost-effective examination to undergo. As mentioned, there's no treatment for sensorineural hearing loss, but potentially effective management of OSA in this cohort of patients may halt the progression of hearing loss and potentially lead to an overall improvement in quality of life. Thank you very much for listening. These are my references. I can take some questions now.
You looked at how long your subjects had sleep apnea in that relationship.
So that's something that I think would have been useful in our questionnaire. So all patients were referred as a new diagnosis. So these patients weren't known to have OSA prior to the studies themselves. So ideally, I think looking back on it, an additional question about perceived duration of snoring may have been helpful, but potentially these were all new referrals.
I wondered, I mean, you measure air conduction, I presume, with this meter. Is bone conduction would be affected given that it's generated internally?
Yeah, I think that's a really interesting idea, because I think if you look at the potential cause of the hearing loss itself, you've got the noise itself with the air conduction damaging the hair cells, but I think the actual vibrational effect of the snore is potentially also a causative factor. I'm not sure how we could potentially differentiate between the two. When we looked at the actual audiometry results, there was no evidence that patients had a conductive hearing loss. It was all sensorineural, and the studies do suggest that hypoxia and the noise itself does present a sensorineural hearing loss, but I think potentially further studies looking at that sort of bone conduction and the vibration effect may be quite interesting to look at. Yeah, so that's definitely another area that we could look at. There have been some previous studies that have looked at patients who snore without OSA, and it does look like they have an increased propensity for hearing loss. But in our study, the majority of patients did have a diagnosis of OSA. I think if we had looked at the control group, so patients who snore without OSA, as another way of looking at that, that could have been interesting. But I think in order to get the numbers for that would have been quite difficult.
Just a comment, when my wife complains about my snoring and selective hearing loss, I can say it's an entity.
Thank you.
You may have saved some relationships. Okay. Warren. Now Warren has two presentations, but we'll split them. So this is the first one. Which one are you doing first?
Yeah, good afternoon, everyone. My name is Warren Sell at Internet Dara. Today, I'll be presenting my study on deep learning to predict lymph node status on preoperative staging CTs in patients with colon cancers. Firstly, all authors declare no conflict of interest. Our clinical staging of colon cancer is crucial in surgical planning and targeting neoadjuvant treatment. This is performed by radiologists in detecting lymph nodes within preoperative CT scans. However, lymph node staging accuracy remains low. We may be able to overcome this limitation by utilizing AI models to predict and detect lymph nodes within preoperative CT scans. Earlier studies have shown that radiomics, a type of machine learning model, have been used to predict lymph node metastasis in colon cancers with only partial success. Deep learning, which is a subset of AI that has the advantage of automatically and adaptively mapping out spatial hierarchy of features through its convolutional neural layers, is emerging as a more effective tool to detect subtle information from medical imaging. However, there is currently no evidence around predicting lymph nodes in colon cancers. Therefore, we developed a deep learning model and evaluated the ability to predict lymph node status on preoperative staging CT scans in colon cancers. This was a collaborative effort between Rao Colorectal and AML. We performed a diagnostic cohort study. To run our deep learning model, we included patients diagnosed with colonic adenocarcinomas who underwent surgical resection with regional lymphadenectomy at the RA and St. Andrews. And we primarily acquired CT scans with the specifications as listed above. Each axial CT sequence was then labeled either node positive or negative. To assess the accuracy of the machine learning model against the true end staging, also termed as the ground truth, we compared the end staging reported by the model versus the surgical pathology specimen. We included a total of 1,201 patients. Our training cohort, of whom we fed the model, had 401 patients. Our validation cohort, or the cohort that selected the best model, had 100 patients. And our final testing cohort had 500 patients, which evaluated the model's performance. Our second testing cohort was prospectively collected, which included 200 patients as well. We utilized image segmentation, a method in which a digital image is broken down into various subgroups within an image to highlight a region of interest in that image. By segmenting the regional lymph nodes within the CT scan, it reduces the need to process the image in its entirety, thereby improving accuracy and reducing inference time. This is an example of 3D image segmented in our input. The red dots displayed are the regional lymph nodes mapped around the colonic veins segmented in blue. This was performed in all our patients within the training and validation cohort. I will now try to explain convolutional neural networks, which is the basis of our model, using this example of the CT slice. This is an area of deep learning that recognizes or specializes in image pattern recognition. Using this abdominal CT slice, us humans can clearly see that this is a lymph node, but to a computer, this is just black and gray pixels. We use filters within the CNN to predict features within an image that represents a lymph node. A filter, or a sliding window, is a 3x3 block that looks out for a specific pattern, for instance, an edge. We convolve this with an equivalent 3x3 block in an image to cross-match this pattern for an edge, and then label this a numeric score with a higher signal strength when an edge is detected. We move along the columns and continue this process until we map out every 3x3 block within an image. Now, this is just for one filter, but we can have other filters looking at simple features such as shape and size, and this is just within one layer. But as we progress deeper through the layers, we can extract more abstract features that us humans may not detect, forming an output. So we developed two models, a segmentation and classification model, both using the ResNet50 model architecture, comprising of 50 convolutional layers. The segmentation model highlights the location of lymph node within an image, while the classification model identifies what is node positive or negative. We input 501 segmented CT slices into the segmentation model, which then generates a prediction mask of what is and isn't a lymph node. And this is then cross-matched with the ground truth. From the segmentation model, which places an assistant row, the predicted positive slices would then be input into the classification model for diagnosis, in which a probability value would be the output. We had a total of 1,201 patients with a median age of 72. 54% were males. There was significant difference in all clinical pathological characteristics between all of our cohorts. In our validation cohort, our AURC score is 0.62, which meant that the model had a 62% probability of predicting lymph nodes. The accuracy, which is defined as the correct predictions over total number of predictions, was 57%. We had very excellent sensitivity scores of 96%, meaning the model was good at predicting positive lymph nodes. However, our low specificity indicates that the model mislabeled a lot of negative results as positive. Likewise, in both testing cohorts, our AURC averaged around 50%. We had strong rates of predicting positive lymph nodes. However, it was very difficult for our model to label negative results correctly. In conclusion, this is to date the largest diagnostic study to use deep learning to predict lymph node staging on preoperative CT scans in colon cancers. Our study suggests that the ResNet50 model is not reliable in comparison with current clinical standards, due to its low predictive ability, despite its higher sensitivity scores as compared with radiomics-based models. So what role does AI play in lymph node staging? I think we're still in early stages, and perhaps a focus on radiomics-based machine learning models may be a breakthrough in predicting lymph node staging as a promising alternative to a radiologist's interpretation. Thank you for listening.
Why are you using CT scans and not PET scans?
I think just based on protocol, CT scans are more widely used across the world. Just looking at local advances in regional lymph node metastasis. And therefore, we use CT scans, abdo-pelvis CT scans, to look at nodal staging at the first instance.
Did you just look at texture, because you suggest that your eyeball can detect better than the machine? What about just texture and outputs?
Yeah, so there's a couple of parameters that we looked at, some texture, grayscaling, motion artifact as well. But the beauty of deep learning models is that we don't define the parameters to the model. That's usually radiomics-based machine learning models. Deep learning, because of its multiple and deep convolutional layers, it sort of extracts data that us humans may not detect. So in short, I don't know what they extract or what features that they can predict, but what we can predict and what we can identify is the AOC values, which is what makes machine learning so interesting. Yeah, so we use ResNet 50. The 50 comes from the 50 convolutional layers. You can have more layers, like you can have ResNet 110, but it requires much more computational power. With more convolutional layers, you then add model complexity because you are having more than 50 nodes that the filters or the layers have to go through. And when you develop a model for real-life clinical implementation, you want it quick and you want it standardized. And so it's sort of a Goldilocks problem where you need to balance reliability versus model complexity. And the ResNet 50 or 50 convolutional layers is sort of the sweet spot in which we're found to use. And that's why we use 50 convolutional layers.
Very much. Let's welcome Colette next.
I think we're good up there. All right. Hello, everyone. My name is Colette Massey-Westrop, and I'm a surgical resident here at the Royal Adelaide Hospital. Today, I'll be describing my research into establishing normative pinch strength data for the Australian population. By the end of my talk today, I hope that you'll have an understanding of what pinch strength is, why it is important, and why the knowledge of normative pinch strength data may be useful in your clinical practice. The manual dexterity afforded to us by our opposable thumbs is a massive evolutionary advantage. So much of modern day life revolves around using our opposable thumbs, from holding a pen to ordering Uber Eats on your iPhone. Pinching refers to the physical movement of gripping or squeezing an item between the thumb and one or more fingers. The ability to pinch combines motor coordination, sensory awareness, and joint integrity. Pinch strength specifically refers to the isometric strength that's used when performing a pinching action, and with modern tools can be measured in kilograms. Pinch strength may be an important measure in the rehabilitation of various conditions that you come across in your clinical work. For example, in plastic surgery, where I'm currently rotating, pinch strength is monitored sometimes post-operatively following a hand trauma. It may also be relevant in many neurological or also rheumatological conditions, just to name a few. Now that you know what pinch strength refers to, I'll break down the term a little further. There are three types of prehension movements between the thumb and the fingers. You can see them here. There's 2-point pinch, 3-point pinch, and lateral pinch. Lateral and 3-point pinch are considered to be the strongest of these movements. These three movements are what were important and what were measured in our study. This study aimed to determine normative ranges of pinch strength in healthy Australian adults of working age and to investigate the influence of age and gender on these normative values. We wanted to measure pinch strength using an affordable, commercially available tool to increase the relevance of our data. A secondary aim of this study was to explore the relationship between benign joint hypermobility and pinch strength. I will not talk about that in detail due to time limitations today. A convenient sample of adults aged 18 to 65 was sought through networks of staff and students at the university. 4 data collectors were trained in pinch strength assessment by a certified hand therapist, and all patients were positioned for their pinch strength assessment according to the American Society of Hand Therapists clinical assessment guidelines, using pre-prescribed verbal instructions that were given to participants. Lateral pinch, 3-point pinch, and 2-point pinch were each measured 3 times each in a random order to avoid the effect of fatigue, alternating between the left and right hand, with each hand resting for about 30 seconds in between each measure. As we aim to determine normative data, careful exclusion criteria was applied, and participants were screened for pre-existing conditions that could affect their upper limbs using the standardized Nordic questionnaire that's shown up on that screen. Hand dominance was assessed by using the revised Edinburgh Handedness Inventory. A total of 250 eligible men and 270 eligible women participated in the study. Of those screened, an additional 40 were deemed to be ineligible to participate due to the exclusion criteria I've already identified and were not included in our final data set. To demonstrate the relationships with pinch strength and age, gender, and hand dominance, we required 23 or more participants in each age group to meet our power calculation. This slide's very busy, but it does show our normative data results, which are displayed in kilograms with a 95% confidence interval. The mean and the standard deviation in our results are also shown. The statistical analysis we used and the interpretation were prospectively designed by statisticians, and these were re-evaluated after we received our results and found that our data was normally distributed. Observation of this normal distribution was created by using box plots, separating men and women, and observing each type of pinch within each age group. Confidence intervals were calculated for men and women of each 10-year age group, as you can see up here, and we separated right and left and each type of pinch. The higher number of participants you can see there in the younger age group is a reflection of the convenience sample used in this study. Unfortunately, it was very difficult to recruit patients over the age of 45 despite collecting data for about 4 years, because many of these patients already had a diagnosis of or had symptoms that were consistent with osteoarthritis, which was not necessarily an unexpected finding. Here you can see the results looking at the effect of hand dominance on pinch strength. Hand dominance in our study population was observed in accordance with normal and expected values. And similarly to previous research, we did not find a statistically significant relationship between age and hand dominance on pinch strength, but gender had the greatest influence. The findings of our study are in keeping with predicted values and represent the largest global and only available data set for normative pinch strength values in a healthy Australian population. In keeping with previously published literature, this study found that pinch strength was most related to gender, but not predicted by age, hand dominance, or hypermobility, as I briefly touched on before. This data set could be used in hand rehabilitation protocols and as an outcome measure to assist in quantifying a patient's progress following a hand injury or another condition that would affect their pinch strength. This objective data is also I hope will also be useful in return to work programs to ensure the safe resumption of some occupations following an injury. I hope now that you have an understanding of what pinch strength is, why it's important, and why normative data may be useful in your clinical practice, whether that's in pinch strength or in other fields. Thank you.
This tells us what the population need is, but what's the clinically significant lower level of pinch strength? Have you ever discerned anything about what's clinically significant?
I think it's clinically significant to establish what we expect to be a normal baseline. A lot of the previous research that I looked through breaks down pinch strength assessment into various conditions, whether that be a tendon injury such as in surgery or in an arthritic patient if they're being measured in a rheumatological clinic, for example. I think having a knowledge of what a predicted baseline is also important, because if a patient comes in and presents to you after an injury, for example, you may have a target that you're going to be working towards, and you may actually be able to tell that patient whether or not the pinch strength that they're presenting with is normal or not. I think the clinical relevance is also that you're able to somewhat quantify a feeling or frustration a patient may feel if they notice subjectively that their pinch strength is off, or that their hands aren't working as well as they may hope, and that you may be able to provide them with some objective evidence to sort of supplement or motivate them to continue with their rehabilitation.
Usually the dominant hand, the preferential use of the dominant hand because muscles in that hand to be better developed. So are you surprised that that wasn't predicted?
I think if you think about it yourself, that would be a fair prediction to make, that your pinch strength would be stronger in your dominant hand. But previously published literature doesn't support that, and our study certainly didn't. And we definitely had power calculation to show that. I think that it somewhat shows that in modern day life, we are fairly ambidextrous with a lot of the activities that we are doing. And perhaps as well, when you do concentrate on performing a movement, such as in a pinch strength assessment, in a formalized process, your weakness actually may be more subjective to a real life setting.
Was there I just didn't quite get enough time to absorb.
That's okay, there was a lot of data up on that slide.
Was there a big range of grip strength within each group that you studied?
No, there wasn't. And I thought within the scope and time frame of this presentation, I won't include the box plots. We found our data was fairly normally distributed. I think that having a really good protocol on how we measured pinch strength and having well-calibrated instruments helped with that. We didn't find a significant variation. If I go back to my slide, which I won't because it's just there's too much on there, the standard deviation in all of our age groups wasn't significant. So we did feel our data was normally distributed. Thank you.
I'd like to welcome Bethany up next.
Good afternoon, everyone. My name's Beth Morgan. I'm an intern here at Carlin, and I'm delighted to be able to present our case control study of SGLT2 inhibitor DKA, in particular some factors predicting the rate of resolution and some important implications for clinical practice. As many of us in this room would know, SGLT2 inhibitors are being increasingly prescribed following the 2018 international guidelines that endorse their use as second-line agents in addition to metformin for managing type 2 diabetes. In addition to the endocrine setting, they're also being increasingly prescribed for their cardiovascular outcomes, heart failure benefit, and a reduction in the progression of known renal disease. However, despite their many uses, reports began to arise in 2014 and 15 of diabetic ketoacidosis with normal or moderately elevated blood glucose levels as a concerning adverse effect of their use. Current real-world data since these original reports has varied in terms of incidence. We at Carlin would see up to 2 cases a week. However, the literature that we found also states it occurs at a rate of 1.8 to 4.9 cases per 1,000 patient years. So certainly not an insignificant disease process, and as we continue to prescribe these medications, it's important to understand the pathophysiology and how that relates to our current treatment protocol at Carlin. I'll just very briefly touch on the pathophysiology just to highlight that it's inherently different to that of type 1 or hyperglycemic DKA. There is ongoing action of the SGLT2 inhibitor in the proximal tubule of the kidney that leads to ongoing glucosuria. So in times of acute stress on the body, as highlighted here as surgical stress, this leads to a change in the ratio of glucagon to insulin that favours lipolysis and subsequently the production of free fatty acids and ketone bodies in the liver. The key point to take away in this pathophysiology is that there is an uncoupling of blood glucose levels and ketosis. So when we think about that uncoupling, it's interesting to note that current international guidelines and our own local Carlin protocol suggest treating SGLT2 DKA with the same protocol that we use for type 1 or hyperglycemic DKA that uses a fixed rate of dextrose with variable insulin administration based on the hourly blood glucose levels. However, as we've just seen, the pathophysiology is inherently different and results in lower blood glucose levels that are unlikely to be sufficiently prompted to increase insulin levels per hour and subsequently are likely to prolong ketosis. To investigate this, we performed a retrospective case control study of 37 SGLT2 inhibitor patients and compared them to 20 type 1 DKA patients at Carlin over a 2-year period. We used the EMR or Sunrise to identify cases through admission diagnosis of DKA and endocrine consultation requests for DKA. Our primary outcome was the time to resolution of DKA as defined as a normalization of bicarbonate to greater than 20 and a ketone concentration of less than 0.6. And our secondary outcomes included the amount of insulin administered and the ketone and bicarbonate normalization. I just wanted to highlight a few of the key findings between the two groups. First were that they were well matched for age and gender, and that the BMI did not significantly differ between the two groups. However, the weight did, which is to be expected in the type 2 diabetic cohort. Second were that the SGLT2 inhibitor group, as expected, showed a lower blood glucose on admission, on average with 14 compared to 35 in the type 1 group. When comparing the DKA itself, the SGLT2 inhibitor group showed a lower severity of DKA, as highlighted by a lower ketone peak and higher bicarbonate nadir. However, despite this, they experienced a significantly longer duration of ketosis compared to the type 1 group, which I've highlighted in this slide. It's quite striking to see that it was almost double the time for the type 1 group. And if we look on the right-hand side, one patient was experiencing ketosis for up to 96 hours, which is quite a feat. When we consider this duration of ketosis, it's also interesting to note the amount of insulin that was administered in the first 24 hours, in that the SGLT2 group received a meagre 44 units on average compared to 87 in the type 1 group. And this lower insulin administration is despite these patients having a higher weight and also insulin resistance as part of their disease process. We then analysed the trend of bicarbonate and ketone recovery with an increased insulin administration rate. And while it didn't quite reach statistical significance, there was certainly a trend of recovery of both, up to 3 units of insulin per hour. To highlight again, the key points of our study were that while these patients had a lower severity of DKA, they had double the time to resolution, and this is likely impacted by the lower amounts of insulin administered. This recovery rate has enormous implications for Carlin and patients overall, in that they are in hospital for longer, which obviously carries with it increased costs to the hospital system and increased bed pressures when we are already pressured from COVID. We find that the current protocols are not sufficiently prompted by the lower blood glucose levels in SGLT2 inhibitor DKA to increase insulin levels. And this different pathophysiology could warrant its own specific treatment protocol that uses increased insulin with a fixed increase in glucose, either through rate of fluids or percentage glucose in fluids. And a prospective control trial would be of benefit. Thank you very much.
I know you've proposed a trial, but has this changed management of the whole phase already?
We still use the same protocol. We still use the type 1 protocol. Yeah.
In this study, was there any delay to the recognition of the US?
Yeah, occasionally, because a lot of the time they are often asymptomatic as opposed to the type 1s who can come in quite unwell. And in a number of our patients, they were also found incidentally in the perioperative period when they were having blood glucose and ketone checks as well. So that could have certainly played into the duration of their ketosis too.
How do you distinguish SGLT2 DKA?
Sure, well, the precipitating use of an SGLT2 inhibitor would lead us down that path as well. But we could also consider the response to insulin and treatment protocols that we use. But yeah, certainly something to consider in the patients that we had.
Can you be a bit more specific about what new protocol changes you propose?
Yeah, so it would be beneficial to continue to use the insulin dextrose administration with an increased rate of dextrose, either through an increased percentage of dextrose administered with the insulin or rate of fluids, to ensure that there's enough dextrose being administered to be able to counteract the ongoing glucosuria in the kidneys. Thank you.
For our final presentation, we welcome back Warren Xiao.
Good afternoon, everyone again. My name is Warren Sell at Intern at the RA. Today, I'll be presenting my study on postoperative variations in anemia treatment and transfusions, a snapshot audit of 2,730 patients undergoing major abdominal surgery in 56 hospitals in Australia and New Zealand. Firstly, we have no conflict of interest to disclose. Anemia is common in patients undergoing surgery and negatively impacts perioperative morbidity. However, current management of perioperative anemia is variable. We aim to assess the compliance with patient blood management guidelines in surgical practice and the impact on patient outcomes after major abdominal surgery within Australia and New Zealand. In this presentation, I'll be using 4 pillars to illustrate the 4 key practices listed in the patient blood management guidelines. The first pillar is to identify and manage preoperative anemia. The second pillar is intraoperative use of tranexamic acid to minimize blood loss. And we focus perhaps more on postoperative anemia to assess restrictive blood transfusion practices, as seen in the third pillar. And we also wanted to highlight an emerging problem, the impact on postoperative anemia, as shown in the last pillar. This was a prospective multi-centered cohort study across a 4-week period performed by a network of students and trainees. We collected patient data as listed above and included over 2,730 consecutive adult patients undergoing all major abdominal surgery across 56 hospitals in Australia and New Zealand. Our audit standards are as defined here in this table, which includes all the 4 pillars as explained earlier. Out of the 2,730 patients, 57% were females with a mean age of 56. A majority of them were head bill surgeries, with 25% emergency cases, with an average length of stay of 3 days. Our first audit standard was preoperative anemia management. Almost 1/3 of patients had preoperative anemia, and iron studies was performed in 35% of these patients. We found that more than half of these patients had iron deficiency anemia. However, only 32% of these patients received IV infusion preoperatively, with an average hemoglobin of 108. Conversely, in patients without anemia, iron studies was performed in 23%, 45% of which had a ferritin of less than 100. Intravenous iron was given to 9% of these patients with an average hemoglobin of 133. Now, comparing patients with iron deficiency anemia that received IV iron preoperatively, patients were more likely to be undergoing colorectal surgery. Outcomes were unchanged between the groups, with no difference in blood transfusion, major complications, and mean hospital stay. Similarly, the use of IV iron in patients with iron deficiency with or without anemia did not impact blood transfusion, major complications, and mean hospital stay. What we can observe from this data is that less than 5% of patients received IV iron. In our study, we looked at this in quite a lot of detail, and what was quite interesting was that none of them had a repeat hemoglobin, and even in those patients with IV iron, even in an overall cohort of close to 3,000 patients, we could not see any difference in patient outcomes. Adherence to the pre-op audit standard was achieved in 70% of patients and was associated with lower rates of intraoperative and post-op blood transfusions, lower risk of major complications, and a shorter length of hospital stay. Next, we look at operative tranexamic acid use. The use of tranexamic acid appeared highly selective in emergency gynae cases, as patients were much more anemic due to blood loss, and those likely required more blood transfusions. Looking at patients that received intraoperative blood transfusions, which represents surgeries with potentially significant blood loss, only 28% received tranexamic acid. Now, the take-home message from this is that in Australia and New Zealand, we are hardly utilizing tranexamic acid. And in light of the recent POISE-3 randomized controlled trial suggesting improved outcomes with tranexamic acid use in all surgeries, perhaps tranexamic acid could be a focus on the patient blood management guidelines. As we move on to the third audit standard, transfusion practice within Australia and New Zealand overall seems to be good, in line with audit standards with restrictive transfusion guidelines. It followed in more than half of our patients. Post-operatively, 6% of patients received at least 1 blood transfusion, and all had a hemoglobin measurement prior to transfusion with a mean hemoglobin of 73.9. As a point of comparison, the same audit was performed in the UK and had a mean hemoglobin of 82. The last audit standard looked at postoperative anemia management. The Sankey plot on the left demonstrates the change in prevalence of anemia across each time point as shown in the stacked bars. The ribbons between the bars demonstrates the proportion of patients from each group contributing to the subsequent time point. Now, what this Sankey plot shows is that anemia develops during the course of hospital stay, with up to 2/3 of patients having post-op anemia on discharge. In fact, we followed patients up to 30 days, and very few patients had follow-up hemoglobin. And as we've shown that severe anemia is associated with doubling of admission rates, this could be an area of future research. Now, so wrapping it all up, going back to our 4 key pillars, our study suggests that pre-op hemoglobin optimization leads to better outcomes. And we also showed 2 areas of potential improvement in patient blood management guidelines. And this is that these guidelines could focus on intraoperative transaminase acid use, and we also need to consider the impact and outcomes of discharging patients with postoperative anemia. Also, we also showed that a network of medical students and junior doctors can undertake a meaningful audit practice across Australia and New Zealand. And last but not least, we'd like to thank the following organizations for the support of this study. Thank you so much.
What do you think the main barriers to admissions adhering to
I think, firstly, on the surface level, I don't think a lot of people are aware of these guidelines. Secondly, with clinical practice, we fall prey to having personal biases. And so, for example, for transaminase acid use, it's not very commonly used in a lot of major abdominal surgeries, a lot in gynae, but not so much, and some in orthopedics, but not so much in major abdominal surgery. So I think education and advocacy for these guidelines should be the #1 priority as well.
You said that the outcomes were poorer if they didn't have the pre-op iron transfusion.
Yeah.
That's what you said. So can you give us what outcomes? Just what was the main difference?
Yeah. So this being a snapshot audit, we looked at, we tried our best to delineate every single step, but perhaps our study may not be too overly powered. But when we look at the algorithm as a whole, it showed that that audit compliance was associated with less blood transfusions, less major complications, and improved and shorter hospital stay as well. So yeah.
That was one. Yeah.
Hi. Is there any, what are the risks of post-op with TXA? And how do you balance that risk?
Yeah. So I think you're right. I think that's one of the main concerns and one of the main shortfalls in using transaminase acid use is that it sort of pushes the patient to a thrombotic event. The truth is, I'm not too sure what the significant risk of it post-operatively, which could also mean why some people are a bit afraid of using transaminase acid use. But there was this randomized controlled trial called the POISE-3 RCT, and that showed that transaminase acid use intraoperatively showed no difference in post-op complications. Yeah.
Thank you very much. We'll give the judges a short time to deliberate. I'm hoping that there is food outside the door that you can avail while they do that, and then you can come back in to find out the results. Thanks everyone for staying while the judges perform their difficult task. I'd like to thank all of our presenters today. It's a really great roundup. I cannot believe how interns have had the time to devote themselves to research. And furthermore, congratulations to all the part-timers. It's really quite something to be undertaking significant research while you're working clinically at the moment. It's harder than ever. But I'm very pleased to announce that we did feel that Jonathan Arayaratnam was sufficiently of merit to be awarded the full-time prize for his presentation. Please come up, Jonathan. Just wait, you need to get a photo with media and comms here. Thanks very much. And the part-time winner was a difficult decision, but I'd like to congratulate Dr. Colette Massey-Westrop. very much. And I'd like to very much thank our panel of judges, Professor Vigila May, Professor Paul Reynolds, and Associate Professor Christine Jackman. And thank you all for coming. Thank you very much.